So our next talk is again going to be by Dr. Tanveer Rab on approach to the chronic kidney disease patient. Dr. Tanveer, please go ahead.
Thank you again. So I'm going to go to this topic about approach to the chronic kidney disease patient. I have no disclosures. So there are two different, phenotypes in chronic kidney disease. One, patients who present with acute coronary syndromes, and in four different publications involving thousands of patients, it appears that in chronic kidney disease, the incidence of acute coronary syndrome occur in 30% of the cases. However, if you look at that the invasive procedures in these patients are generally lacking, and most of the patients with chronic kidney disease, it appears through data that they do not get invasive procedures versus their non-chronic kidney disease cohorts in the community. Now, it has been shown that if you look at a study by Shaw published some years ago, that as your GFR decreases, as your kidney failure worsens, in the dark gray bar, you can see that inpatient angiograms are not performed in this group of patients, maybe because of the fear of morbidity and mortality and high procedural outcomes, versus in patients who do not have chronic kidney disease. And a lower GFR, it appears that patients and physicians are avoiding doing procedure in them. However, if you look for the benefit, patients with the lowest GFR, eGFR of less than 30, appear to have better benefit with PCI versus optimal medical therapy with an adjusted odds ratio of 0.80. In contrast, patients with stable CKD, patients with stable CKD, still, again, they still get less invasive procedure and versus other groups, versus patients with non-CKD who are stable, who get a higher percentage of invasive procedures. And in the ischemia CKD trial, which was for stable CKD patients, there was no difference really in outcomes for patients with chronic kidney disease in invasive and conservative arms. So you've got two groups of people with ACS and CKD who are not getting the therapeutic effects of revascularization versus those in CKD which are stable, who really have no benefit from invasive versus conservative procedure. The other thing to know about is that in chronic kidney disease, you have associated issues with the heart, and EDP is very important. From this important study with hemodynamic guided hydration, it appears that you have to be cautious about EDP and not overhydrate these patients who are not in dialysis. A rising EDP above 15, prehydration, giving lots of fluids can be hazardous to them, and they cannot really excrete out the excess volume, and they can go into pulmonary edema. So you have to be very careful about how you hydrate individuals with CKD. So it's very important to have hydration protocol in your system. So standard hydration is pre-procedures, normal saline, 250 over 2 hours, then 100 ml per hour, 5 hours, then 30 cc an hour to the procedure, generally in patients who are overnight. However, currently in our outpatient population, we hardly get this amount of volume in, but it'd be reasonable to, at least in patients with CKD, to bring in them a little earlier and start giving this hydration at least 4 to 6 hours before the procedure. Low volume hydration is people with LV dysfunction who can get normal saline 100 ml per hour, and no hydration, generally patients with decompensated heart failure or end-stage renal disease, dialysis, etc. Post-procedure, standard hydration is 250 now for 4 hours, total of 1 liter. People have modified that depending what contrast you use. More contrast, you use more hydration, but nowadays, if you can use a small amount of contrast, your hydration can be less. Next is low volume hydration and no IV hydration, particularly to those with decompensated heart failure. What is the hydration protocol from the President study? Is normal saline at 3 ml per kilogram per hour during the procedure, and 4 hours post-procedure if the LVEDP is 18. Normal saline to 1 ml per kg per hour during the procedure, and for 4 hours post-procedure if you have a higher EDP. In our population here, we have a lot of patients with hypertension and end-stage renal disease, and we really are very cautious about how to hydrate these individuals. And of course, you don't give any hydration post-procedure if the EDP is more than 24. What about contrast volume? Contrast volume is based on eGFR. Very simple. If your eGFR is 60 or something like that, you should not exceed that contrast use. Also, Um, I'm going to interrupt. Bashir, would you mind telling the other hall that I'm running a little behind because they're texting me? I apologize for that. Uh, let me answer the other hall and tell them I'm still in hall B. Sorry. So contrast volume, very simple. If you get an EGFR off lab results, if your EGFR is say 45, you should not exceed that amount. If your EGFR is 60, you should not exceed that amount. In new systems, you should only use 3 to 6 cc's of contrast injection by diagnostic study and 3 cc's for puffs and PCI. There should be no contrast puffing for catheter engagement. If you know where you are, the vessels, particularly the left coronary artery, you just inject 10 cc saline and you'll see some EKG changes on your monitor that'll tell you where you are. And then you should remove, when you remove catheters for exchanges, you should remove the contrast from the catheter before you do the exchanges, so you know what exact amount of contrast you're using. For ventricograms, generally, if you need to do that, generally you can get a good idea of the LV function from an echo, but you have to do that and use half dilution with saline and inject only 20-30 cc's with a PSI of 700. If creatinine is 1.5 and contrast dose hasn't reached, you should defer PCI for elective cases. What about ultra-low contrast? Ultra-low contrast is volume of contrast administered if the eGFR ratio is less than 1. Contrast-induced nephropathies increase in serum creatinine greater than 25% compared to pre-procedure within 48 to 72 hours of procedure, or increase in serum creatinine equal to or greater than 0.5 from the baseline. How do you do contrast optimization? You should do low magnification, no panning. You should obtain left coronary artery, 2 views only, like a apical or spider or cranial view. Those are only 2 views you need, really. And inject 3 mils of contrast for each view. And RCA, get an LAO cranial. So you can do good study if you have a good camera in your system, a modern camera. You can visualize everything in less than 10 mLs, and that's all you need for diagnostic studies. Now, what about wiring blindly? For example, if you've taken a set picture, like a single image, a reference image, and you can know where your artery is, you can, if you're a good operator, be able to wire down the LAD. This wire on the other side shows you that it tracks the LAD, and sort of after you cross the lesion, buckling is okay. And similarly, you can do the same thing for the diagonal branch. Now, in certain monitors now, for example, in the Philips system, there's what is known as a dynamic roadmap. It creates a roadmap from your last reference, and when you pull it up on your pedal, this is what you see, and you can wire based on the roadmap. You don't have to inject any contrast. And I'll show you the example of case I just did, where, this is a reference roadmap, and I'm trying to wire it, and you can see my wire is going to first to diagonal. The lesion is more proximally, that's what there's. Buckles the lesion, pull back the wire, and then I can migrate the wire. It goes to the septal over here, down to distal LAD, and that helps preserve contrast. Now, in certain systems like Philips, which have integrated systems, you can only get a reference over here. Then you can do other things based on this reference and the dynamic roadmap. For example, you can push a pressure wire. You can see where the difference or where the stenosis really is, and then you can, for example, in this panel here, you can do co-registration without giving any more contrast, so you know the length of the lesion stented. And you can use IVUS to determine the reference vessel diameter or the plaque burden. And then you can size based on this co-registration without giving any more contrast. You can stent. And then you can, after doing all that, you can take a final picture. So all these tools are available in newer integrated systems for your use. Finally, the other tools you can use, if you don't have that, you can use your dual 2E or something like that, or use your normal 2E that you have. For example, in this case, you have a reference image here, you have a lesion here. You've got your operating wire down here. You can put a second wire or marker wire down. Remember, from the tip to the dark portions, always about 3 centimeters or so in most wires. You pass an IVUS down and know where your distal landing zone is, and push your marker wire to that point and bring the ultrasound back and know your proximal reference zone. In this case, you're pretty close to the end of the marker wire. You can estimate that a 28 or 30 millimeter stent might work without giving you more contrast, and do the final angiogram. So just a brief overview of CKD, the issue of ACS and CKD patients not having adequate angiography, where they have the most benefit, versus stable CKD patients, which can be monitored conservatively, and tips and tricks about hydration and the low volume contrast tube. And I thank you.
Thank you very much, Dr. Tanveer Rab. Great talk, excellent review for everything we need to know. I think as an interventional cardiologist, somebody who's already has CKD is always a concern, and excellent tips how to avoid and decrease the amount of contrast to decrease the risk of worsening renal function.